audience today. And one thing I've learned over the years, even though the audience might be small, you can never underestimate the change one talk can make to one person. So I trust that today will be one of those days. I'm sure more people will join as we go along, as usual, but it is really wonderful to see all of you here. And once again, gives me great pleasure to welcome you all on behalf of the Gastro Foundation, who hosts the iEcho program, who have brought us into the fold thanks to Professor Chris Cassianides. And this all is done in association with Project ECHO at the University of New Mexico, as you know. So these sessions are held weekly on a Wednesday, and we have PBM sessions less frequently, usually every 2 months. And then intermittently, or all the other Wednesdays, there are all other kinds of gastroenterology topics on hepatology and viruses and gastroenterology, etc. So sure, for the gastro people in the audience, that is something that would be of great relevance to them. But the PBM audience, of course, is one that's quite different. And so very great to have the hematologists and the anesthesiologists and the surgeons and the transfusionists and everybody else with us as well today. So with all this, I am really grateful to welcome Professor Katarina Pavenski, and I hope I say that right. You must please help me if I got that wrong. With us today. Now, it's interesting how the world works, because she was introduced to me by email, or through email, by Claire Barrett, but we actually had worked together on the ICTMG, which is the International Collaborative for Transfusion Medicine Guidelines, working on a platelet guideline, which I hope will come out in the near future and will be a game changer. I'm not allowed to say anything more, but I can say, if you want to see a game changer, you must see that one. It's going to be very interesting. So Prof. Pavenski is head of Division of Transfusion Medicine, clinical hematologist, and medical director of the Patient Blood Management Program at St. Michael's Hospital in Toronto, where she's also the medical director of therapeutic apheresis, and she's an associate professor in the Department of Laboratory Medicine and Pathobiology at the same university. And she's particularly interested in clinical transfusion, patient blood management, and therapeutic apheresis. Just as a side note, Katarina, we are busy doing a manual exchange transfusion for a patient with CML and hyperleukocytosis with a count of almost 700 today, because we didn't have the necessary parts for the apheresis machine, which will only be there tomorrow. But anyways, we've done it before. She's also vice chair of the ICTMG, the International Collaboration for Transfusion Medicine Guidelines. She's chair of the Patient Blood Management Subgroup of the ISPT Clinical Transfusion Working Party, and she's also regional director for the North Americas of the ISPT Board of Directors. So I don't think I could have invited a better guest for this session. She's going to talk to us about a very special program, the ONTraC program that was developed in Ontario, in their province, and we're very interested to hear how it works. Can we do this here? What are the lessons you've learned? And yeah, so over to you. A big South African welcome. Actually, this is not just a South African welcome. There are many people here from other parts of Africa too. So, but a big welcome to you, Katrina, and thank you for making the time to join us today.
So thank you, Vernon, for this introduction. I am going to now hope to share my screen again. I know we've done it before, so just bear with me. And here we are. So it is my great pleasure to be here with you today, and especially talking about the program that as an Ontarian, as a St. Michael's physician, I'm extraordinarily proud of. Oh, why is this not advancing? Okay, there we go. If you're interested to learn more about this program, I do want to advertise this article that has way more information on this program. And I'm happy to share the PDF of this article as well if there is an interest. I'm not sure if it is free access. What I'm hoping to do is to talk about the program, to discuss some of our achievements, but also really spend a chunk of time talking about challenges and lessons learned, with the hope that those on the call who do not have a formal PBM program can potentially learn and not repeat our mistakes and hopefully take from our successes. I don't have any conflicts of interest related to this talk. In my benign hematology realm, my interest is TTP and immune cytopenia, so I participate in trials for those conditions. So I'm going to start with a definition of patient blood management. And I know that for most of you on the call, you're probably well familiar with this concept. This is the definition that encompasses both the WHO and sub-M definition. It concentrates on branding patient blood management as first and foremost patient-centric, evidence-based, and with the idea of not just preserving blood transfusion for someone else, but with the idea of improving the patient outcomes in front of you. It's interesting that WHO first talked about PBM like 12 years ago, but more recently actually sent out a call for urgent need for implementation of patient blood management, highlighting that it should be a standard of care and it is a principle of ethics and equity to have patient blood management available across the globe. What are some of the attributes that make patient blood management what it is? It's the fact that it's personalized. It has to be tailored to the individual's medical problems, comorbidities, but also preferences, and ability to pay, and ability to access. It has to be timely. It should be ideally multimodal, and it should be equitable. Most of you probably have seen the picture on the right that comes out of Australian publication now from a few years ago, describing the pillars of patient blood management in the context of surgery. So things that you do pre-surgery, during surgery, and after surgery. But since PBM is not just about surgery, I also included on the left what WHO describes as the 3 pillars of PBM. The first pillar being you need to detect and manage anemia. The second one, optimization of coagulation and reducing the amount of blood loss. And finally, leveraging the patient-specific physiological tolerance of anemia, which broadly is interpreted as using restrictive transfusion strategy. And I'll go in a little bit more detail about that shortly. And because I really wanted to talk about practical things, like how we actually do things, I won't have too much time to go into the evidence behind all these things that we are doing. But I do want to remind, for those of you who are less familiar with patient blood management, what is the actual rationale for patient blood management? And it rests on the following few conclusions that can be easily derived on review of literature. Anemia is common. It is very, very common. It is especially common in Africa. Anemia, even mild, is associated with adverse outcomes and increase in healthcare expenditures. Anemia also puts you at risk of allogeneic transfusions, and allogeneic transfusions may not be always safe or readily available for your patients. And even if you don't think about classical complications of transfusion that you may think of, like transfusion-transmitted diseases and, TRALI, there are a number of adverse outcomes associated with transfusions, and they're costly. So what is the evidence for some of these patient blood management programs? I'll just show you a few examples before I start talking about our own program. So this systematic review, which is about now 5 years old, included 17 studies spanning different countries and about 250,000 of patients. And the authors were able to show that formal patient blood management programs can reduce allogeneic transfusion rates by 40%. They can reduce, so even if the patients are getting transfused, they're getting transfused less units. But more importantly, the hospital length of stay is decreased, the complications are decreased, and they even showed that there might be a benefit in mortality. Some of the more famous or more publicized patient blood management programs are the ones from Western Australia. So this is the famous Leahy publication showing multitude of improvements, again, linking back PBM to reduction in mortality, reduction in infection, reduction in thrombotic events, as well as very sizable decreases in blood product consumption, as well as healthcare costs. And the last one I'm going to show you is the one from Germany, where the German Patient Blood Management Network was recently evaluated and shown that across about 1 million surgical patients, patient blood management has resulted in the reduction of transfusion and also the number of units transfused per patient. So looks very, very good. But one question that comes up, and I know it still is quite controversial, is patient blood management sounds really good, but is it actually cost effective? And the reason it's controversial is because just like blood is expensive, so are a lot of patient blood management interventions. Cell salvage is quite pricey. So the medications like intravenous iron and erythropoiesis stimulating agents. And they can be associated with their own complications. If you try to sort of apply universally across the board, everyone should get EPO, everyone should get IV iron, you will invariably harm people as well. So when you consider the totality of evidence, is it actually worth it? And when you just look purely at costs, so cost of blood saved versus things administered to reduce that blood transfusion, it comes out pretty much cost neutral, perhaps even in disfavoring PBM. But when you start taking into account the lengths of hospital stay, lengths of ICU admission, infections, et cetera, you can actually start to see that patient blood management programs are actually cost effective. And I encourage everyone to read this paper. It goes into great details on how this model has been derived. For those of you who had the ability to join us in Barcelona for the last ISBT Congress, you probably heard Yashasvi Dimant from India speak about our project on survey of patient blood management programs across the globe. So we had 16 countries participating. Sadly, we didn't have anyone from South Africa. And more of these results will be published in Vox Sanguinis sometimes in the very near future. But what we found is that when you look at formal PBM programs, only half of the respondents had them. And the other thing that we found is that I say they were more prevalent, but really it was invariably these formal patient blood management programs existed only in higher income countries with no programs in lower and middle income countries. Even though we definitely saw evidence of people's interest in PBM in these countries, formal programs were not established. And when we asked them about the barriers, and I'm going to talk more about the barriers, but there are a lot of common themes here, is lack of knowledge of PBM amongst physicians, insufficient resources, poor multidisciplinary collaboration, and the biggest problem of all is acceptance amongst us physicians that transfusion should be a default rather than trying alternatives. So when this publication is available, I do encourage you to take a look at more details. And the reason PBM is sometimes lost in translation here's another 7 European university hospitals multi-center survey, is again not a lack of awareness, lack of screening for anemia. So more than 50% do not routinely screen patients for preoperative anemia. And arguably, the evidence for screening and management of preoperative anemia is actually the strongest amongst all the other patient populations. And some physicians would simply view transfusion as a way to manage anemia. So there's no alternative, so we just go straight to transfusion. So, and this, I promise you, this is the last introductory slide, and I'll tell you more about our program, but I think this is important. This is another absolutely excellent publication on some of the barriers and drivers of patient blood management and its implementation, and it was across diverse countries. And so one of the most important drivers identified were patient outcomes. And I cannot emphasize enough that the biggest impetus for patient blood management implementation is improvement in patient care. Yes, it may save you money. Yes, it may get your patients out of hospital faster, but the most important thing is to make your patients better and have better outcomes. This group also asked about accelerators and inhibitors. And again, please read the paper. There's lots of really, really interesting tidbits in those papers. But the biggest accelerator, as answered by this group of participants, was generation and publication of local data. And this will become important for our subsequent discussion. And the biggest inhibitor was low awareness. And finally, who are the stakeholders influencing patient blood management implementation? Number one, policymakers, ministries of health. And it's interesting because one may not think of immediately, they may think of, I don't know, subspecialists in anesthesia or surgery, for example, driving patient blood management implementation. But the most influential, it appears, is policymakers, Ministry of Health, and this was definitely a key to our success. So with that introduction, let me tell you more about ONTraC program, which is a provincial patient blood management program spanning the province of Ontario. So the province of Ontario is the largest province by population in Canada. We have about 15.5 million population spread over 1.1 million square kilometers of area. What's interesting is that unlike some other programs, ours was launched actually quite a long time ago. Ours was launched in 2002. And to put this into some sort of context, this was right in the wake of what became known in Canada as the tainted blood scandal, when there was realization that there was testing available for HIV and hepatitis C, and yet untested blood or incompletely tested blood was released, and as a result, a number of recipients got infected. And there was a very significant commission of inquiry into this that resulted in dissolution of Canadian Red Cross and subsequent formation of the Canadian Blood Services, the current blood supplier, and established a lot of principles. But in that inquiry report, there was a lot of mention of how important it is to tell the patients that they're being transfused, to offer alternatives to patients. And perhaps this was fertile ground then to approach the government and say, hey, we can make this better by starting a patient blood management program. So this program is administered through my hospital, St. Michael's Hospital in Toronto, but it is spread out across the entire province. And the founder and medical director of this program is Dr. John Friedman, who is originally from South Africa, and a very stubborn man who refused to take no for an answer and essentially spent days lobbying the government for giving us funding for this program. This was, of course, before my time. So currently in its present state, we have 25 hospitals and 28 coordinators. And the reason these 25 hospitals were chosen is because these hospitals accounted for the very, very large chunk of what was being transfused in my province. So not accidental. And really the aims were very simple. we wanted to reduce unnecessary transfusions in targeted elective surgical patients. So it was the very, very focused programs, and the priorities were set by the government. So at the time, if you were in a cardiac center, your priority was coronary artery bypass, plus minus valve replacement, as well as major joint arthroplasty. So very common surgeries, and at the time, very bloody surgeries. And if you were in non-cardiac centers, you were given an opportunity to intervene on some other types of surgeries, but these were all targeted elective surgical patients. And the other very important thing was to provide provincial benchmarks for these procedures so you can compare peer to peer, and also as a result, promote patient blood management activities. So when I talk about ONTraC, we really, really are focused on pillar one, which is detection and management of anemia. And the way we do this is we created resources on how to screen patients for anemia, and what blood tests to perform for screening, and how to treat them subsequently. And that's what you can see on the right. This resource is freely available on our website, which is www.ontracprogram.com. And basically what the 28 nurses in 25 hospitals do is that they go to what we call in Canada a pre-admission facility. So this is a clinic run by anesthesiologists who are seeing patients identified usually at higher risk of complications for their pre-surgical consultation. And they would screen the patients for anemia. They would also accept direct referrals from anesthesiologists, as well as if beforehand a surgeon's office wants to refer a patient that they're concerned about, they could do so as well. And the nurses would assess the patient, order the appropriate blood work as a medical directive. They would review the blood work with the patient blood management physician. So in this case, at St. Michael's Hospital, it would be me. And I would prescribe treatments as per our protocol, taking into account, of course, the patient's comorbidities and preferences. And if we cannot fix the problem, we will also facilitate referral to other specialists. So that's how we are operating. We also spend a lot of time of promoting PBM activities through education, mainly rounds, and putting our nurses and physicians on multidisciplinary committees throughout the hospital. So we are visible as a branded, identifiable program. And more importantly, we collect data. And collection of data is phenomenally important. So what do we do in terms of management of anemia? Well, that makes sense. If the patient is iron deficient, we give them iron. We can use oral iron or intravenous iron, depending on how quickly the surgery is approaching, how tolerant the patient would be of their side effects. We also look into account patient's compliance, access, cost, ability to come back for an infusion versus they live very far away, and therefore we will have to make do with oral iron. Sometimes, occasionally, we would also recommend to the surgeon anesthesiologist to postpone the surgery if it is not urgent and we're confident that we can optimize their hemoglobin further. We also use erythropoiesis stimulating agents. This is a bit more controversial than giving iron to iron deficient patients. We usually, for this, target patients with high risk of transfusion, so usually sternotomy, open heart surgeries. We usually use it in conjunction with oral or intravenous iron, and the dose we use is 40,000 weekly until we reach the hemoglobin target, and we strictly adhere to these targets. So the general target is set at 130, whether you're male or female. And if you have a history of chronic kidney disease or cancer, the target is set at 120. And that is because previous evidence has pointed to increased risk of arterial events in CKD patients, and increased rate of venous thromboembolic events in patients with cancer if they are treated with these agents. And unlike some other initiatives that I will show you, this is based very much on the personalized treatment plan. So we're not giving EPO to absolutely everyone. EPO is considered to be something that we would consider down the line if we do not believe that iron will work, and we will consider contraindications, preferences, and of course, ability to obtain coverage for these very expensive medicines for our patients. And for those of you who may wonder where this evidence comes from, so erythropoiesis-stimulated agents have been known for years to reduce the risk of transfusions. This same systematic review also shows that the risk of thrombotic events as a result of their use in this setting is not increased. Our own group conducted this systematic review and shown that if you combine erythropoiesis-stimulating agents and iron, you can further reduce red blood cell transfusions. So I said I'm going to return to data. So one of the things that was built into our program is that the nurses not only assess patients and come up with plans and administer some of these patient blood management plans, they would also collect data. And that data will be reported back to the Ministry of Health, and these data will also inform future direction and decisions, et cetera, et cetera. One of the most important outcomes was benchmarking. So this is an example of a true letter that St. Michael's Hospital will send out to participant hospitals. And it goes directly to the CEO of the hospital saying that we are pleased to share with you the results of your hospital, and you ranked, you tied for first in terms of knee, but perhaps you're doing very poorly in terms of cardiac surgery, and they will give you literally your standing across other hospitals where you are in terms of transfusion rates and PBM interventions. And I cannot overemphasize the point that our hospital administrators are incredibly competitive, probably just as competitive as surgeons and anesthesiologists, who I see by seeing these data would really want to be the best and facilitate the implementation of this program being driven by these data. There are a lot of other things that I'm not going to be able to show you today, but collection of data allowed us to learn a lot of other very interesting things. And some of these things you may eventually see as publications, and some of them have been presented in conferences, and some will remain forever as just a quality improvement initiative. But for example, we found that lead time matters a great deal. So the more time you have, the more chances you have to intervene on patients. That multimodal patient blood management is superior. So if you can combine iron with potentially another PBM intervention, you will have better outcomes. Makes sense. We were actually able to show without data. We also showed that unfortunately oral iron has limited efficacy in our setting. That is not to say that oral iron is not effective, it's just our lead times are so short that oral iron just has no ability to move the needle on the hemoglobin before surgery. Another one that is already been published in Vox Sanguinis, coming out shortly publicly, is that women should be prioritized. Why? Because they are much more anemic on referral on the day of surgery, and they have the lowest nadir hemoglobins compared to all our patients, and they have much higher red blood cell transfusion rates, and that's whether it's major arthroplasty or cardiac surgery, and therefore we should be prioritizing women. We also found during COVID that we couldn't bring in our patients to pre-admission facilities, so we needed to make do with limited blood work that was available. So we started to use reticulated hemoglobin, which is one of those things that gets read out on CBC. If you use a Siemens analyzer, and I don't have any conflicts of interest related to Siemens analyzer, we decided we have this marker, maybe we should use it, and we actually validated as 32 as a useful marker of iron deficiency, and that saved us from bringing the patient for further blood work. The other really important thing that we decided to do is to involve patients. And so we, for years, have been giving out pamphlets to patients about what patient blood management is, what is EBO, what is iron, why you would take it, what are some of the side effects. And we found that patients never really read them. Why? Because at the time of pre-admission facility visit, they would be given lots of pamphlets on pre-rehabilitation, the surgery itself, the consents for transfusion, what to do with their medications. There was such a massive overload of information that patients ended up not remembering anything at all about related to patient blood management. And so we partnered with University of Toronto, a master's program, in biomedical communications, and we had a student develop an app for anemia management. Unfortunately, we didn't get funding to go further with that, but our subsequent project worked out, and this is a freely available 3-minute animation. So if you scan the QR code in front of you, you will be able to view the video. It's less than 3 minutes long. It uses animation to trail 3 different patients, very different 3 different patients going for their surgical journey, introducing patient blood management, introducing different treatments available, and introducing the concept of patient blood management team. So strongly encourage you to use it. When we finally published the evaluation of this video, amongst patients, so we had very good response from our patients on it. It became one of the most downloaded articles in transfusion on the theme of patient blood management. So this is something that was viewed by our readers as of importance. So I'm going to quickly go over Pillar 2 and Pillar 3. In terms of ONTraC, we really concentrate on Pillar 1. But what I can say is that having the program being part of our blood literally for 22 years literally changed the environment in which we operate. So further initiatives became more palatable, more easier to implement, because we were socialized to the concept of patient blood management. And so sometimes even starting with Pillar 1 in surgical patients and nothing else will produce other downstream positive effects. So let's talk about Pillar 2, which is optimization of coagulation. Tranexamic acid is extremely important in stabilization of the clot. It is cheap, widely available medication. If you want to read more about tranexamic acid and some of the evidence and controversies, I cannot recommend more this illustrated review that is also from St. Michael's Hospital, and actually the first author is our transfusion medicine fellow. It is freely available. It's open access. It's a beautiful presentation with lots of really, really good pictures. The fact that TXA works in elective surgery, we've known for 12 years. There have been multiple systematic review. I'm showing you one by Kerr, 11,000 patients, showing that you can reduce transfusion rates by 1/3 just by giving TXA during surgery. But it is widely effective in trauma, postpartum hemorrhage, and other conditions. Another Canadian led randomized controlled trial, absolutely massive, just published 2 years ago in New England Journal of Medicine in non-cardiac surgery, showed substantial reduction in bleeding outcomes if you were to use tranexamic acid. So tranexamic acid has extremely good evidence to support its use in patient blood management. So this is now going back years, but one of those low-hanging fruits. Some of our patients, so all of our cardiac surgeons and anesthesiologists have adopted using 100% tranexamic acid during on-pump surgery. But we said, well, what if we're going to do this as a universal for major joint surgery? And so this was for knee and hip arthroplasty. This is literally the card that was like a job aid that accompanied our policy. That all patients, unless there was a specific reason to opt out, so this is one of those universal, non-tailored interventions in patient blood management, will be getting tranexamic acid, 20 mg/kg intravenously, right in the OR, administered by anesthesiologist right before the surgery begins. And prior to implementation, our utilization rate of tranexamic acid was roughly 50%. So usually the patients who were chosen for this intervention were the ones who were already anemic or had, it was a redo surgery, so there was a concern for additional bleeding. Following implementation, so this was from 2015, currently we stand at 100%, essentially with very, very few exceptions of TXA used in arthroplasty. And as a result, our transfusion rates for primary hip or knee arthroplasty is 0. We do not transfuse. zero. So this is one of those, and at least in Canadian money at the time in 2015 when we implemented it, it was $11 per dose Canadian to result in massive improvement in transfusion rates, getting the patients out of the hospital faster, reducing infections, etc. So it was one of those things that was very easy to sell to our hospital administrators and was widely implemented. It was subsequently implemented across other ONTraC sites, but this was a St. Michael's-led initiative. And finally, the last thing I'm going to show you is stopping the bleeding. I don't want to go too much into this, and maybe it's not a problem in South Africa or Africa, but in Canada and other high-income countries, bleeding patients for laboratory sampling is a very big problem. And patients very quickly become anemic. So if you get admitted following a myocardial infarction, 60% of patients will be anemic by the time they leave the hospital. 100% of ICU patients by day 3 will be already anemic because we've bled them repeatedly for this. And this hospital-acquired anemia has now been associated to worse patient outcomes, and such as mortality, for example, longer lengths of stay, as well as higher costs, because all of this phlebotomy, you're processing it, your lab is paying money for it. And is it always necessary? And there have been a number of choosing wisely campaigns. I'm showing you the one from Canada because I happen to be Canadian, but there are ones from the United States and other places basically showing, urging physicians to stop doing unnecessary blood testing. And again, from St. Michael's Hospital, there is this review on overutilization in laboratory medicine showing, highlighting the what exists in literature on this topic. And so what did we do? Well, we stopped routine draws. So there's nothing routine CBC ×3 daily. We unbundled tests. So sometimes you just need an INR. Do you absolutely need your entire coagulogram? No. We implemented CPOE. And at first it was so that's computerized physician order entry, which gently said, you know, you don't want to order this again. And then eventually stopping rules. So if you ordered it and it's not appropriate, we will tell you it's not. We implemented mandatory screening of all order sets by the lab. And the future is this, which are low vacuum soft draw tubes, which are the same size, which means they don't mess with your analyzer settings, but they draw less blood. And this Canadian trial has shown that you can save on the blood that you collect from your patients. And when it was piloted in 25 adult ICUs, 21,000 patients, they were able to save 1,500 units of red blood cells. And that did not come at the expense of insufficient volume for testing. That was exceptionally rare. So this smaller volume was enough to do all the necessary tests without affecting patient care and also not making them anemic. So this is the holy grail. And so hopefully this is where we're going to move next. And finally, restrictive transfusion. The recent updated international/ABB guidelines endorsed restrictive triggers for most hospitalized patients, with restrictive trigger being somewhere between 70 to 80 or 7 to 8, depending which what units you use. And the other important thing about restrictive transfusion trigger, restrictive transfusion strategy, is using single unit transfusions for those patients who are stable. And if you want to read more, using bloodwisely.ca is a freely available website that tells you exactly how you can, gives you ready-made tools that you can immediately take and start implementing this in your own hospital. And so how did we do this? Well, it greatly helped that Accreditation Canada, which accredits all of our hospitals and hospital transfusion services, dictates that all physicians who order blood must undergo mandatory education. So do nurses. And so it was very, very helpful that all of a sudden we had a forum that everyone had to attend. Then we went ahead, so we obviously passed the message of restrictive strategy and implemented then computerized physician order entry with decision support, and with retrospective auditing, we're able to get our designation as using Blood Wisely Hospital, and we're maintaining it. So even those this and tranexamic acid were not strictly speaking ONTraC achievements, having ONTraC at our site made implementation of those substantially easier. So what we have achieved over the 20 years or so, you can watch on this graph what happened to the transfusion rate in single knee arthroplasty, going from somewhere about 30% to 0, and coronary artery bypass surgery going from somewhere of 60% to about 30%. Not only the rate of transfusion has decreased, we also decreased the number of units per patient transfused, but more importantly, lengths of hospital stay decreased. Percent of patients with infection was less in arthroplasty as well as CABG if they avoided transfusion. And the program cost was $3.4 million Canadian. This is just to pay the salary of our 28 nurses. Some of them are part-time. And if you just look at the cost of blood, it's 14.6 million in savings. But if you actually take into account the hospital stay, it's close to 37 million. This one is harder to interpret because what we try to do is to show that we're actually reducing red blood cell utilization in our province as a result of this program. And as you can see, Ontario always seems to fare better than the other provinces collectively taken. However, I think patient blood management message is penetrating, whether you have a program or not, because the overall utilization per thousand population has absolutely dramatically dropped, starting somewhere from sort of 2008 and so forth. So now we are sort of stabilizing, because I think maybe it is as low as we can go, but again, only future will show. And finally, with great success of ONTraC program, we caught attention of the country, and a national statement on patient blood management was just implemented a few years ago, and I had the privilege of participating in the development of this document. So let's think about what helped us. Government support, absolutely paramount. Dedicated funding for patient blood management nurses. PBM was immediately framed as a priority by the province, which means that the CEO was being told by the Ministry of Health that this is important and where the ranking is. And I think focus has also helped. Sometimes we run in many different directions and unable to achieve anything. And the fact that there was unwavering mandate from the government to address these specific things allowed us to stick to the plan and really excel in execution of that plan. Nurses are the backbone. Dedicated nurses is what makes or breaks the program. And what is our take is that all the nurses that get hired, even though they're hired in different hospitals, we train them on the same set of protocols. We also provide centralized training and centralized continuing education. So once a year, they meet up together in Toronto, and we go through the updates in literature, updates in different conditions, et cetera, et cetera. So we are trying to send the same message. Mandatory data collection on PBM interventions and red blood cell transfusion rates, absolutely phenomenally important. That allowed us to provide accountability to the Ministry of Health. And it also allowed to establish provincial benchmarking, which drove the interest in patient blood management, and collaboration is important. If I were to think back, what were sort of the things that were really impeding our progress, it's the fact that in Canada, blood and blood products are very, very safe. So the risk of HIV transmission in Canada with a red blood cell transfusion is less than 1 in 21 million. Very, very safe. Blood is always available. There have been very, very few shortages that we had to live through. And it is free to hospitals and patients. So we pay as taxpayers for the cost, but no one else sees the bill. And it's convenient, right at point of care. You just have to write transfuse, and here you go, blood comes out. Whereas transfusion alternatives, the cost is borne either by patients or hospitals. It's complicated to get access to them sometimes. And it's inconvenient because if you want to have now the patient come in for IV iron or EPO before surgery, that's extra time of work. And again, the onus is on the patient, the onus is on the physician to fill out the appropriate paperwork. So there's a great disincentive to do that. We did a really good job with nurses, but dedicated PBM doctors, we don't have that. And some of the nurses who ended up in hospitals with no champions or physicians interested in this were sort of flailing and not doing as well as the ones who actually were picked up by the champions of that organization. Complacency and lack of knowledge remains a problem as well. Late referrals, lack of awareness amongst patients, we're trying to address. And so if you, after all of this, you're inspired and you want to start, I think my biggest recommendation is to try to seek government or at least regulatory support. The fact that transfusion education is mandated, is absolutely necessary for physicians and nurses, gives you a platform to educate them about things that are important to transfusion medicine and patient blood management. Money for the nurses that are dedicated and recognizable is a huge accelerator, is a huge bonus. Having a dedicated team so people know who you are, they see you, and they know that you are PBM is very important. And I would say start small and smart and persevere, educate, and collect data. If you don't collect data and you're not able to show what you're accomplishing, you will not have an audience with your hospital administration, your government, your physicians. And you absolutely need their involvement. And so I'm going to stop talking. I know I went a little bit more than I thought I would because I like to talk so much. So I'm going to stop sharing and I'm going to take questions.
Sure, Katarina, that was a fantastic overview. Thank you so much. Can I ask anybody listening, you're welcome to unmute your microphone and ask your question or put it in the chat. Very welcome.
I see Michael Henry has hand raised. Please go ahead.
Great. Okay.
Thank you very much for a delightful presentation. Prof, can I ask you to please elaborate a little bit more about the small volume testing tubes? I didn't quite get what you said there about them being compatible with the analyzing machines, and that was a low
vacuum.
vacuum.
So in the past, so thank you. This is actually, it's a really good question. And it was a problem why we couldn't move with something like this earlier. So if you want to reduce the amount of blood that you collect for laboratory testing, you can order less. That's education of physicians and other forcing functions, or you can use pediatric tubes. The problem with pediatric tubes is that they are tiny, and a lot of our analyzers, so again, we have a big lab with the automated line and it's set to a specific height. So it was impossible for our line to accept these pediatric tubes. So in fact, in my institution for pediatric tubes and neonatal tubes, we have to do them manually. There's no way to put them on the machine. And of course that slows down efficiency. These tubes, and I can't even tell you who manufactures them, but I'm sure we can easily look it up. They're the same size as your standard test tube. So there is no problem with your analyzer. You can just load it the same way as you would load the existing ones. The difference is that they have less vacuum. So that's why they're called soft draw. And because they have less vacuum, they draw less blood into it. So all you have to do is swap them out in your all areas that use tubes. You will collect less blood from the patients. You could still fit them in your analyzer and you're still able to do all the tests you may want to do. So this is why I say it's holy grail, because it's one of those things that you're not relying on physicians, you're not relying on anyone else. It can be entirely done in the lab. And in fact, unbeknownst to most phlebotomists or nurses, they had no idea that anything has changed. And yet it had this dramatic impact.
Okay, that's awesome to know. Could I just ask Prof. Vernon Lowe, Prof, do we do this in South Africa?
I think that's one of the issues, is that we don't have that particular type of tube as yet, and something that we will have to try and get. And I actually wanted to also, just on that note, I thought I'd heard about a tube within a tube system where you have a pediatric sized tube almost built into a adult sized tube so that it can be accommodated by a normal machine. Is that something you've come across?
So we do not use that. So I've heard of them, but when these tubes became available, it kind of, there's no need to pursue anything else. That seems to
Yeah,
be the
sounds
solution.
fantastic. Sounds wonderful. And I think that will sort out our problems too. So something for us to follow up on with our labs. I don't know if there's anybody from the lab in the audience. You're welcome to let us know if you know anything about that.
And of course, they need to be, approved by your government, etc. So there is a regulatory part to it. Luckily for
Of
us,
course.
these
Sure.
were available and approved.
So I think one of the things that stands out for me, and I'm becoming more and more impressed by, is the key role of nursing staff and nurses. It's a great need in South Africa, I think, as in many other places where we have great nursing shortages in general. But I think that is certainly something we should pay more attention to here, is training nurses up. And they might have to have dual functions within our hospitals, because I don't know if our hospitals will easily
Can
appoint
spare a
nurses.
nurse just for that, I know.
Exactly, because of the cross-functionality required by most of them. The other thing that I just wanted to say, that article you referred to on tranexamic acid is fantastic. I've shared it before on our patient blood management group. It is open source, and it is really, really great. So again, people, those of you who haven't seen it, you can let me know. I can always send it on. So that was very good. So in terms of the medical team and the involvement of your anesthesiologists and surgeons, do they just sort of let the nurses do their thing, or to what extent do they get involved with questions that the PBM nurses might have, or do the PBM nurses contact your home base, so to speak, I'm thinking about patients with difficult to diagnose. Is this iron deficiency or not? Does this patient need iron or not?
So this is a fundamental, and this is what I was saying, that if having an assigned physician responsible for PBM program is very important. So in my hospital, I am the transfusion physician, but I'm also in charge of patient blood management. If I have two nurses who are ONTraC nurses, they go and do the triaging and figuring it out. Then they come back to me and we literally discuss the cases. And what would happen afterwards is that we would then communicate our plan to the anesthesiologist and the surgeon who were involved in this patient care. And we would say, this is beyond us. This is acute leukemia. We've already made a referral to like hematology. And believe me, this actually happened to me once, which in the pre-admission facility, which is wild. Or we've identified iron deficiency. We have taken the liberty of booking your patient for IV iron such and such time. So there is a communication going. Sometimes what happens is that we believe that the patient can benefit from optimization, but there is no time because the surgery is tomorrow. So at this point, I would usually engage in a conversation with both anesthesia and surgeon about possibility of delaying surgery. It's a very touchy subject. And usually anesthesia sides with us and a surgeon may have a different opinion. And a few times they may say, no, it may appear elective, but this person has, I don't know, rapidly progressive heart failure. They need the surgery right away, in which case we would say, okay, proceed with surgery. We will manage your patient in the post-operative period. So we have, again, it was a COVID outcome. We've popularized giving EPO right in the operating room, right before surgery, and then following up with intravenous iron in the intensive care unit or on the ward to sort of give the possibility of recovery to reduce the amount of blood that would be required. So so it is all a matter of this communication. Some of our surgeons have become so socialized to the concept of patient blood management that they would email me or my nurses directly, and they would say, oh, I just saw this patient, her hemoglobin is 79, I'm going to operate on her foot, can you do something about it? And so they completely defer to us to take this further. Now, this is what happens at St. Michael's Hospital, which a lot of colleagues refer as the ivory tower, where everything works the way it should be and there are resources. So some of our nurses, especially in the community hospitals that are far away, do not have access to a champion or a designated physician. And then it may become, well, I'm not sure, is this iron deficiency, or this is iron deficiency and anemia of chronic inflammation, or is there a myelodysplastic syndrome going on, and all these other complicated things. Anesthesiologists are not always in the position to be able to answer these questions and provide them the support they need. And surgeons really, they do not want any part of this because they believe that this is outside of their training and scope of practice. So in those cases, we have seen, so there are some hospitals that did not perform very well in ONTraC because you want to prescribe EPO, well, you need a physician to prescribe it. A nurse cannot prescribe iron or EPO or any of these things, cannot even place a referral to another specialist under our environment. And if you don't have anyone, then you can't do very much. And so they've resorted to giving some counseling on taking supplements and iron-rich foods, which is not the same as the kind of like full involved consultation that happens at our hospital. So this is why I say, to me, I'm very proud of our program. But I think the weakness is not having the designated physician who really should be a hematologist, or maybe anesthesia with extra experience in hemostasis and hematology. Sure. And I know that there are those specialists as well in other countries. Otherwise, it's unfortunately wasted effort.
No, and I think you've got very good reason to be proud, and we've got reason to be jealous. So, or at least to go and try and emulate what you've done. But I think what you also said was very encouraging. There's something all of us can do. And I also think that the anemia optimization and finding a cause for the anemia as another downstream benefit is huge and something everybody can do. So that's great. And on that note, you mentioned the RET-HE of less than 32 and that you validated that. I found that interesting. I just want to share with you a slide quickly. Now, I hope, oh my word, where is this now? I thought it would just come up on my screen. Oh, here it is. I'm just going to share a quick slide. We just did this is in press with pathology. It will be, well, should be published soon, but basically this was looking at quite a large population of patients who had actually had bone marrows, where I think I can show the number here. We started off with I think 700 or so, and then eventually of those with adequate sampling, we ended up with 139. But at the end, what was interesting, so just get the right slide, is that the RET-HE performed okay in the patients without inflammation, but actually performed quite poorly in those with inflammation. We ended up with, wait, let me just go past this. We ended up with this, which was quite a bit different from what we're currently doing. But this actually gave incredibly good sensitivities and specificities where we actually did not use the RET-HE at all. But I just wanted to have your thoughts on that.
Oh, 100%. I will never use RET-HE in the absence of a need to if I'm unable to have ferritin, if I'm unable to have CRP, our current testing algorithm includes ferritin and CRP and
Okay.
TSAT and all those other things. It's
All
just
right.
for COVID, they would come in, well, they would not even come in to us. They would go to a private lab, they get a CBC, that's all we got.
And then you've got the red HE at hand. Okay.
Exactly. The
Makes
other big
sense.
problem for us, so I'm very much looking forward to your paper, is something I'm super interested in, and of course didn't have a chance to talk about. The other big problem for us is that, so I don't know if it's understood in South Africa, but Toronto is the most diverse city in the world.
Oh, wow.
So there are more than 100 languages spoken, more than, I don't know,
Amazing.
200 ethnicities reside in the city of Toronto itself. So a lot of patients with thalassemia.
Yep,
And
that says
without
everything.
the iron studies that
Exactly. Okay.
reticulated hemoglobin is super low, and you don't know if you're dealing with thalassemia trait or iron deficiency. So I would not promote it to use it. I'm just saying that
Sure. No, but
it
that was
was,
interesting comment.
yeah, it was a good solution for, we didn't have anything else.
It makes sense in that setting for sure. Mike, last one from your side, and then I think I have to thank everybody. Wow, we filled the hour. It's amazing. So exciting. Yes, Mike.
Yeah, Prof, I just wanted to ask you, do you have much place nowadays for intraoperative hemodilution in some of your more demanding surgical cases?
So do you mean ANH? Like,
Yes.
right? Yeah,
Uh,
okay.
So what I'm talking about is somebody's going to have massive spinal surgery, and the anaesthetist draws off 2 units of blood,
Yeah,
keeps it at
okay.
the
So
side. At
ANH.
the end of the surgery, gives it back.
So it's interesting. So no is the quick answer. So we use cell salvage a lot for these cases. Again, and there is, I can tell you what the on-track utilization of cell salvage across different sites are, et cetera. I'm not going to belabor point with that. In our own institution, our perfusion anesthesia chose to go with preferentially cell salvage in these cases rather than ANH. And ANH is complicated because there was, we had a great love for it. And then there was a systematic review that basically showed that it was absolutely terrible. We shouldn't be doing it. And so we quickly, there was big education, and it was quickly, so SOPs were destroyed. Everything was removed. We couldn't, no more bags to collect blood. That's it. It's done. It's eliminated. And then other studies came out showing that in select patients is actually a really good thing to do. So we had this big discussion, do we bring it back or not, or do we bring it back for some patients? I think in the end, in my hospital, the decision was made, we'll just stick with cell salvage and don't resurrect ANH. But there are hospitals that use it, and there is evidence. There is evidence that it works in some cases. So I would not suggest to throw it away like we did entirely, especially if cell salvage is not available, because cell salvage is very expensive. It requires a perfusionist. It requires a lot of expensive equipment and disposable, not just the equipment, but also the disposable equipment. And in some cases, you may not be able to afford cell salvage. So especially if you don't have access to cell salvage, I think ANH should be definitely in your armamentarium of things to do. But we do
Excellent.
not
Thanks
use it
very much.
anymore.
Okay,
That's
thank
very
you.
useful. That's interesting to know. In the chat box, everyone, I've put a link to that illustrated review on tranexamic acid. Also want to encourage all of you to keep your eyes open for the ICTMG platelet guideline when it gets published. Katrina, do you think it will be this year or next year?
I'm hoping it's still going to be this year, but maybe very late this year or early next year.
Okay.
Let's leave it at that. Yeah.
Great. Okay, perfect. Now with that, wow, what a wonderful, I'm so glad this was recorded, because there are some areas, some things I'd like to go back to. I need to go and get that Vimeo link, because when I tried to use the QR code, I realized I don't have a Vimeo on my phone and it didn't want to open it. So I've got to get that. And then a big thanks again to the Echo University New Mexico team, the Echo India team. The recordings are available on the Gastro Foundation website. So thank you, Cheryl. Thank you, Karen. Thank you, Gastro Foundation. Thank you to the people who sponsor the Gastro Foundation to do this. And then next week will be for the people interested in gastroenterology, will be the will be lower endoscopy. So, sorry, I think I suddenly clicked on the wrong button there, lost myself. Lower endoscopy next week, so share far and wide. And then I just want to lastly advertise once again, if you are not yet part of our Sub-Sahara Africa Patient Blood Management WhatsApp group, which I now have to admit has now attracted a number of people from Australia and the Americas, which is and Europe, which is very exciting. But you are welcome to email me with your mobile number or send me a WhatsApp directly on this number, which I'll put in the chat. And then I will send you an invitation link. It would be great to have you. Katrina, we thank you. This was great.
Thank you
And
so
we
much.
Thank you.
look forward to
Thanks,
getting you
Katrina.
again.
Thanks, Vernon.
I'm very glad a lot of people joined in the meantime. We were just around 30 at the peak, and I think that's a good number. Very thankful for that. Have a lovely evening.
Thanks
so
very
much.
much.
Thank you.
Bye-bye,
Thank you.
everybody.
Bye, Vernon. Bye, Katrina.
Bye,
Thank
Chris.
you.
Thank you, Chris.
Thank
Thanks,
you.
Mike, as
Thank
well, for
you.
your questions.